what happens in Washington doesn't always stay there. It took very kind of quick turnaround to come to Rock Hill, South Carolina. I'm one of the owners and the CEO of a small physician-owned and operated practice. So if I could do something, anybody else in this room can do that. That's my message to begin with. It's not as hard to transition. I remember Nelson Mandela once said that it seems impossible until it's done. So with that, let me start my journey to the patient-centered specialty practice.
It worked. You got it.
So,
Yep, got it.
okay, sure. So, how patient-centric care is necessary in our society. For those who keep reading up with the IOM report in 2013, there was a report which summarized U.S. healthcare as shorter lives and poorer health. U.S. spends $9,603 with change on an average per year, and we stand 27th in the life expectancy, probably 49th in preventable complications. And Jordan spends $1,000, and their outcomes are probably as good or as bad as what ours are. So many think tanks went down the kind of route of finding out what's wrong with the system, and then they came out with conclusion that our healthcare delivery system is fragmented, siloed, and it's kind of designed to incentivize volume, and there's no value tag to that. So NCQA, Joint Commission, and many other like state societies or maybe ASCO, AUA, all these societies came back with different ideas of improving the healthcare delivery system. And I'm sure it's still learning curve. We have several models going on, but at the end of the day, the three big stakeholders, physicians, payers, and patients, are the foundation of challenges in the healthcare system, and they could be part of the solution as well. So patient-centered quality care can improve care coordination and communication for the patients, establishes very robust and good relationship with the patient. So Bob McCleave is an attorney. Think about an attorney and doctor going together to speak. That's kind of an example of how you can establish a very strong relationship with your patients. It improves the real-time and on-demand care as needed. And there's definitely cost savings, not just to the healthcare system, even to the practice as well. And I'll dive deeper into that, sharing our journey as to how it just didn't become profitable for the system, but also for the practice. It's counterintuitive that when you make investment into practice transition and how you get that investment back. For me, we were practicing in a fragmented way, so it gave us a platform. The patient-centered care transition brought us with a platform to bring the jigsaw puzzle together. So we had scattered ideas, but this model gave us a structure that we can put assembly together to make a nice kind of puzzle. And then I always want to equate the patient-centered care to like each harp on a piano. When you have each chord that you strike on, you get very harsh noise. But when you have a symphony, when you have sequence of coordinated effort, it brings back nice symphony. So the way I equate PCSB transition is we were playing with individual chords, and now we can play Beethoven. For the payers, of course, it results in reduction of the cancer spend, increased patient engagement. Patients want to see what their payers are doing to improve the quality care as well as population health. And it also focuses on the reduction of the avoidable complications. So I'm going back to IOM report back in 2013. Because I'm an oncologist, I have a lot more interest in the oncology part of the equation. That's it. Right, okay. So the summary was the cancer care delivery system was in crisis, and patient care was not patient-centered. Palliative care was not a part of the priority, and treatment was not based on the guideline-based recommendations. So the recommendations were patient engagements, I'm sure you'll keep hearing this word over and over again when you hear NCQA, coordinated workforce, evidence-based care, optimal application of EHR. My computer always corrects it back to her. Sorry.
Darn computers.
I tried 3 times and 4 times I gave up. And really translation of the evidence into clinical practice. And at the end of the day, we can definitely provide accessible, affordable care for everyone. So this is a nice cartoon that summarizes the micro-ecosystem of patient-centered care. Keeping patients and the family in the center, the physician becomes the next piece of the ecosystem, literally providing that shelter. And as an oncologist, I feel that I become an integral, indivisible part of my patient's family. And the workforce aligns around this. So when you look at translation into the patient-centered care, initially it sounds too cumbersome. And for us, when we were going for transition into the patient-centered specialty model and OCM, instead of asking my employees to do more of one and less of the other, we held weekly meetings. We started taking them on a retreat. So last year we went to Buyin, and tomorrow we are going to Asheville. We have about 30 employees, maybe 20 of them will come with us. We sit down with them one-on-one, maybe around the campfire, help them understand that this is not a burdensome government thing that we are doing. We are doing it because we feel that patients benefit from that. And I always give them personal kind of scenario that imagine if you have to go to ER, wait for 10 hours for something that could have been taken care by your doctor on Friday afternoon. What we don't realize is the social and family cost. So if an oncology patient has to go to ER on Thursday night, spend 8 hours, wait there, their family member has to be with them, they have to drive them, and then they get hospitalized. 4 days of antibiotic infusion in a hospital, they get released on Tuesday, and a week later they start developing diarrhea. Why? C. diff colitis. So you actually added a complication of hospital-acquired infection into somebody who already was burdened with disease. Can we avoid it? Yeah, if I saw that patient on Thursday afternoon, I could have brought the patient in, checked the blood count, I could have given them IV antibiotics in the office. Now, it was burdensome to squeeze in a patient, but if I look at business perspective, it added $120 of infusion revenue to my practice. That patient came 6 days in a row, so my practice got $720 more as a new revenue stream. Plus, the most important part is, for my quality of life, I didn't have to wake up at night to take the call, to give ER orders for admitting that patient, and go to hospital 7 days in a row to open up the chart, write the notes. For me, hospital is very inefficient system, not because they're inefficient, but for me to go there, leaving my patients in the office, just that transition adds about 30, 40 minutes of extra time. So it's a win-win for all, for a patient, for the caregiver, for the system, for me, and a hospital will not be penalized because they are reducing healthcare acquired conditions. So what we realized that by taking the 30,000 feet view in buying in from our employees, I can say hundreds of things, but unless I get buy-in from my employees, it's not going to happen. So right now, our nurses are so well trained for navigation piece, is that if they get a call from a patient, they'll ask question, oh, Dr. Patel is here, why don't you come and just we'll take care of you right here. So every day, we see about 3 or 4 walk-in patients, and we've made a system. Now I tell my patients that if you need to be seen, don't even wait to call, just show up at the door between 8:30 to 5 and someone will take care of you. So that has reduced our after-hour call volume. So with about 7,000 to 10,000 active patients in my practice between 5 oncologists, we take call for a whole week and I rarely get called once in evening because we take care of the problem before they arise. So we've taken a proactive approach of addressing the need, and we could do this because we got the what we call the roadmap. We wanted to reach to destination, but how do we reach that? So PCSP ideas and platform from NCQA provided us almost like an architect. They gave us the building blocks or the plan for building the whole home, and that's what we feel the results are kind of very helpful. So coming back to this concept of the microeco system, expanded access, reduced ER visits and hospitalization will reduce the cost of care. Guideline-based treatment will improve the outcome, and patient engagement improves patient experience. So the triple aim of the healthcare, which is reduced cost, improved outcomes, and improved patient experience, they all are achievable by realigning workforce. It's not imposing. And once the employee understands the relevance of these, they want to run with it. So we talked about the patient navigation piece, and one of the nurses who's very vocal in community, she went to different foundations, she went to utility company and say, our patients with cancer may not have money. Can you help them reduce their utility bill? She's been able to get concessions for every possible avenue within the local county. So clearly buying in was very helpful for us. And now I don't have to, like I said, educate. They just come and say, we'll take care of this here. To the point that recently, about a week back, one of our nurses, she's she's not in the other side of the world, so she got offer from big corporations, say, yeah, I want to take up a job there. And our nurses, rest of them came back and said, don't worry, we'll take care of patients. We don't need to hire somebody right now. We'll work a little extra. So it's the buying in from the employees on the model that we are talking about really helps. So we kind of, took this hexagonal approach where we looked at the foundations of the patient-centered approach, beginning with patient engagement. So we have a special booklet that we designed educating patients on who's in the office. So we have each employee's picture on a couple of pages, their roles and what they do to help patients. So that's more like familiarizing with the practice. Then our services, chemotherapy, all this information, who to reach, when to reach, how to reach. Expanded access, of course, we opened up, we have 2 empty slots any given day in the office, 2 locations that patients can walk in. So it can sometimes be a little bit difficult, but when we look at the after hour reduction in the call volume as well as reduced need for us to go to hospital, definitely has improved our ability of serving patients better. Continuous quality improvement. So we are monitoring the call response time and also how many patients we actually saw in the office as a walk-in. So between July 1, 2016 and March 1, 2017, when we had OCM site visit, we had accommodated 168 patients who otherwise would have ended up in going to the ER. And when you put the dollar volume to that, it could come quite high. Of course, EHR, I have some disagreement. People call meaningful use, I may call meaningless use. It definitely has helped. So to be fair to EHR, I think some of the requirements may not make sense, but the platform has helped us to be able to access patients' data while I'm on call. I have my smartphone, so if my patient calls, I can open the smartphone, see what was done that day. So it has helped in improving quality of care. The reporting requirement may be somewhat, could be modified, but on the whole, EHR has made improvement in the quality of care, improvement in quality of life for us and for my employees. Guideline-based treatment would help us kind of, offer the standard of care treatment, and care coordination has allowed us to have better communication with patients and the other physicians. So in patient engagement piece, as I said, we orient them with who we are, what we are by giving them, it's about 50-page brochure that we print in-house. I'm a very thrifty person, so I went to Office Depot and they said it will cost you $35. I bought a small binder, asked employees, can you bind it when you're doing nothing? Cost us $3. So patient education, financial counseling. I'm proud to say that in 17 years that I'm running this business, I've not said no to a single patient, whether you're insured, uninsured, underinsured. And it's because we have a girl, Crystal, she has become so smart in finding out foundations, patient assistance program, free drug programs. For an oncology, some of the drugs could cost $100,000. We've been able to provide it seamlessly. And we've also not thrown our burden to the hospital system. So many practices have a tendency of shifting those uninsured patients to the hospital. We've not created the two-tier system. We don't have a collection agency. We don't work with them. So we have to tell patients that we will send you statement. I have to bill across a line. If you can pay me $1, I'm fine with that. If you can't pay, I'm fine with that, but you'll receive the statements of the charges because following the Fair Billing Act, I have to maintain that. But short of that, financial counseling has helped our patients tremendously. Shared decision making, secondary prevention, we have hired a nutritionist. We don't, this again doesn't make sense. I'm an internist and I'm an oncologist, but for CMS, I'm an oncologist. So I don't get paid for dietary counseling because they said I'm not an internist, because I bill under taxonomy of the oncologist. But we still feel that the secondary prevention in form of lifestyle modification that includes smoking cessation, weight reduction, exercise, improves the outcome. It's been proven beyond doubt. So we felt we can throw in that service as an extra service to the society. Advanced care planning, every patient, whether you are 20 years old, 25 years old, as they walk in, we counsel them for options and we give them 5 wishes brochure, which is a legal document in South Carolina which could honor the wishes of patients in terms of the living will, in terms of the healthcare power of attorney, and the choices. So expanded access, again, patient navigation. When a patient calls, the front desk girl will, depending on what the severity is, he'll bounce that call off to the medical assistant or to the nurses. And depending on that, they'll triage and bring them in. Same-day services, so this will follow with same-day service. Our patients have 24/7 access via phone to physicians, and we all have access to EHR. We opened up weekend hours, so if a patient has to be seen on the weekend for 2 to 3 hours in the morning, one of the doctors will be on site. We provide internet access. And again, I've not turned a single patient away from my practice in 17 years that I've been practicing. And care coordination, again, we have a team huddle that takes place every Monday. MS get together, nurses get together, and they kind of figure out what happened during the week, what they want to do during the week. We also work very closely with other providers, so we call our colleagues, and I can get any patient into the cardiology practice the same day, or GI practice the same day, or even to the bone marrow transplant center the same day. Social workers, we work with the hospital, electronic health records. So all these transition pieces, even though it sounds too much arduous because it's like Washington papers, it's not as difficult to do as what we've done. And again, guideline-based treatment, so we follow national guidelines, choosing wisely. All these components of implementation of the PCSP have helped us distinguish ourselves as a more satisfying and gratifying center, not just for the patients, but even for us as well. So let me kind of give you a 30,000 feet view of how PCSP accreditation aligns with MIPS and MACRA, because I'm here at the MIPS conference. So expanded access is a part of accreditation, reduces ER visits, hospitalization, and lowers costs. Applicable for the APME, yes. PCSP, it's a requirement. And MIPS, yes, because 5 claim-based measures that CMS is going to look at me are going to include the number of ER visits, hospitalization, Patient engagement, it improves patient experience. It's part of the OCM, or alternate payment model. It's also a requirement for the PCSP, and it's also a requirement for the MIPS. EHR, or meaningful use, or now they have a new term, advancing care information, improves communication. It's an essential component of all the three different accreditation process. Quality measures help us standardize the quality of care. It's part of the APM, it's part of the PCSP, it's part of the MIPS. And cross-cutting measures that would help us improve population health, like smoking cessation, BMI, again, part of PCSP, but it's also part of the MIPS. So our investment proactively in moving towards the patient-centered care prepared us for the journey into the alternate payment model, and now we feel that we are kind of seasoned players. And this is our journey, how it all unfolded. So innovation team at Blue Cross Blue Shield met with us to discuss the pilot, and stepping back, why we chose to do PCSP over the other. We have had many options, and I think exploring all the different segments of the accreditation, like ESCO COPI or the PCOP, we felt that this was the closest to our heart of how community practice can deliver better care, and it aligned. They are more practical. They are more they identify more with the boots on the ground. So we started journey, and then by 2015 and 16, CMS announced OCM. So it was just walk into that. We didn't hire any consultant. All we did was lay down what we did for PCSP accreditation as a part of my application. And when CMS chose 190 practice out of 450 applicants, we felt that, we were rewarded for our sincerity and transition into the patient-centered care model. So with this, I'll end my conversation and take any questions.
Thank you for allowing me to speak to you. I haven't done one of these presentations before, so to quote an old trial advocacy professor of mine, there are probably 3 presentations I'll make. The one I think I'm going to make, the one I make, and the one I wish I'd made. But if you can hang with this southern accent, at a minimum, maybe I'll have you speaking proper English in a few minutes. 11 years ago, my life was going probably better than I could have expected. 2 years earlier, I left a 200-lawyer firm and taken the leap to go out on my own as a sole practitioner. And within 2 years, in other words, about 10 years ago, I was probably turned away more business than I was taken. Fortunately, one of the ones I did not turn away was Dr. Patel. I didn't know at that time how important that might be. Starting in the summer of 2007, I noticed I was taking longer and longer naps during the workday. And typical work day for me was 10 hours a day, and then I'd go home and run 5 or 6 miles to wind down. And I noticed by midsummer of 2007, I was starting to get a little shorter of breath, and noticed with each run a little bit worse. So I went to an urgent care center, August 2007, gave me an antibiotic. 6 weeks later, I went back a second time saying, it's not working. My pulse is starting to go up, and they gave me a different antibiotic. Then by November, I went back to that urgent care center, and I said, I'm not leaving until you find out what's wrong with me, because I'm going to have a heart attack. My pulse had gone from resting 60, because I was a runner, to resting at 120. So at that point in time, they finally did a blood test, and the doctor comes back in, ashen face, and the blood levels were, depending on which blood cell you were looking at, were between 1/3 and 1/2 of normal. He said, don't want you to walk out. You might have a heart attack. You need a transfusion now. I was still in denial. I said, I'm not getting any transfusions. So the next day, I was in Dr. Patel's office. because he was a friend of mine. I had access to him immediately, and access at that point is critical from what the studies show. He took a bone marrow sample out of my hip that day in his office, and it was on the way FedEx out to a California lab the same day. And a few days later, it came back, AML, acute myeloid leukemia, at about the 20% level, which is not good. I mean, it's not terrible. Well, it is terrible, but it's 20% is fairly high. It's past the pre-leukemic stage. He had a friend named Gary Spitzer, who's really a specialist in leukemia, and Gary happened to be practicing within a hospital in Greenville, South Carolina, which had some isolation sections for people who were going to be under the kind of chemo I was going to get. So I would go to that. I went to that hospital. My initial round was 7 days a week, 24 hours a day on it's called Aracy, it's a type of chemo, and then once a day they'd add this orange bag. I called it gasoline. I don't know what it was.
Red devil, they call it red devil.
Yeah, but all I knew, they got double thick vinyl on, because if the person giving it to me got it on their skin, it caused a 3rd-degree burn, and that's what was going in. After they watched me to see if I could stabilize after that 7 days, and once I did, I was sent home, and one of the reasons they were able to send me home out of the hospital because they knew I would be under Dr. Patel's care. So each month after that, I would go in for 3 days of what's called high-dose chemo. You might know what that is. If you don't know, count yourself lucky. My layman's view of high-dose chemos, they take you to within an inch of your life, and your body believes you're dying, I think. But the transfusions bring you back. And what they're trying to do, again, I'm a layman, what they're trying to do is take to get to those leukemic cells, they've got to get it all the way down in your bone marrow. And when I'd go into Dr. Patel's and get a blood test, he'd come out smiling. I said, what's you smiling about? And he said, your white blood count is 0.0. And I said, and that's good? He said, that's what we want. Well, that means I had no defense against anything. Cold, I might have survived it, might not have, probably wouldn't have survived the flu. And I mean, I was in such a delicate balance there. I was told no exposure to pollen, don't eat pepper, and I would go home and basically lock myself in my house, but I had access to Dr. Patel. And began the climb back. I don't have anything against hospitals. That's where I got my treatment. But an analogy, I think, is to John Dillinger, who, when he was asked why he kept robbing banks, he said, that's where the money is. Well, hospitals are where germs are. And I wanted to try to stay away from that. And this was 10 years ago, so this was before the set of protocols you have now. It's just because he's who he is, and that's the kind of person he is. And I never had to go into a hospital. I would go into his office frequently. So I divide it into two aspects when you're under that sort of assault to try to cure you. One's the physical, and it's just a reality. You just don't have much of an immune system. If you can stay out of a hospital, particularly an emergency room, I think from my viewpoint, you're a lot better off. And the other aspect's mental, and I can't say which is more important, probably equally important. There's a close mind-body connection there, but if I could diverge a second back to Alaska, when I was in my 20s and 30s, I was in the salmon business there, and part of what I would do half the week was I was a commercial salmon fisherman on the Yukon River. And by August of each year, it would start to get dark in Alaska, unlike the earlier part. So in August, when I knew it would get dark, because you'd only get certain days of the year to fish, and you better make it on those days, because there usually weren't but about 10 or 12 of them. So when I knew it was going to get dark, we had drift nets. It's a net you set out. I was in a small boat. You set it out in the river, and because I knew it was going to get dark, I was going to drift out of the mouth of the Yukon River into the Bering Sea. You're drifting there, and the salmon are coming in and getting caught in your net. And the reason I would do that once it was going to get dark is I didn't have to worry about getting snagged up on the banks or trees or something. I knew I was drifting to the Bering Sea, so it would, and by sunrise I'd be out in the Bering Sea, out of sight of land, but not snagged up on something. And sometimes I didn't have anybody with me because my fishing partner wouldn't show up or something, and you had to go out on those days. But so people would think that's pretty alone in an open boat by yourself in the night, going out into the Bering Sea. You can't see anything. But I knew come morning, and the morning would come, that if I had to, I'd go east and I'd get back to the Yukon Delta. Very worst case scenario, if I got turned around and went west, I'd hit Siberia. I had enough gas for that. I had enough gas. But that feeling of loneliness does not compare to when you've got something inside of you that you can't run from. You can't get away. You can't get enough gas. It can't get dark enough. You can't get away. And people that have not been there can't understand that. And that's where the mental aspect comes in. And if you're lucky enough to be able to get in and see somebody like Dr. Patel, it gives you some sense of hope. Because when your body's under that assault, it's an assault, and it tears you down. And as you lose your hemoglobin, you lose your ability to critically reason anymore. And in an emergency room, they're treating an acute problem. When you go into Dr. Patel or something, they're treating you as a whole person. And I had lost the will to live by the last round of chemo. And I only was given that will to live by Dr. Patel. So that's why I'm a big believer in what they're doing now. And if you're curious what it's like afterwards, from the outside, my life's probably not different from when you saw me 10 years ago. I have a much smaller law practice. I run. And if you're around people that are going through this, I would say to give them some hope. That first year, I thought I would never not spend a certain part of each day in that hospital room with that chemo line in. But that went away. For a couple of years, I thought I'd never be able to fit back in around people because I thought you were all walking in your sleep under a sense of delusion, which I divided into grand illusions and smaller illusions. Still think that to a certain extent, but I have come to realize part of the human condition is to live with a certain amount of delusion. We got to get up and bury nuts for the winter. So that's my story. I don't think I'd be here without the care I got from Dr. Patel.
Thank you so much for sharing.
So I have to ask you, you hear a story like that, and we think about how we try to measure the effectiveness of a program by looking at quality measures and costs, and I wonder whether we're asking the wrong question. Do we want a practice like Dr. Patel's that provides that person-centered connections and longitudinal relationships that allows a man to come here and tell a story like that? So I have to ask. Thank you, Bob. That was incredible. I don't know where to begin after that, to be honest with you. So let me ask you, what questions do you have of our team here?
If you had to pick, when you think about quality measures from a person who's experienced pretty serious illness, how would you try to capture, for those of us who think we know the answers, what do you think the right questions are?
Bob, before you answer, I'll give you a chance to think. I was asked to repeat the questions by our folks here. So the question is, I'm paraphrasing a little bit, but as you think about how to measure quality, what would you want us to measure as sitting where you sit? What would you like us to think about measuring so we can try to, I imagine, to lead to, can we get this done elsewhere? Can we duplicate it? Or can we know when it's being done correctly?
You mean measure in a quantitative sense, or am I hearing you ask what was the most important part of my care to me?
Yeah, I mean,
How would
I
I-
think you have to measure it some way in a quantitative, although it is fairly qualitative, you know. I mean, I think it has to do with aligning with what's important to you, your values and preferences. At least that's how kind of we think about it.
Yeah. Well, I think it was both physical and mental. I mean, quantitatively, I basically lived for each morning's blood test. I wanted to see that blood count. I wanted that doctor sharing it with me. I wanted to know everything. Now, I wanted to know the facts. Don't hide them from me. I want to know the facts because I really do believe that the mind, and I guess I can say it because maybe I was lucky. I think we do not know the extent which the mind comes to play in this. And I wanted to know exactly what was going on with me so that at some level of my brain, I could be doing something about it. So I want the facts, and I want them to be measured, and I want them given to me. And then the other is just what I've said is somehow knowing that somebody is on your team, is vested in you. And I'm not sure how you measure it. I think I've got a lot better chance of somebody being vested in me if I'm seeing them on a regular basis and it's their specialty and I'm their patient versus going into a larger system where they may or may not know me. And I experienced both. So I don't know if I've answered your question about how to measure it.
So I think what Bob has described is exactly what the PCSP seems to be doing. For example, when he said, I want to have my blood count and I want to have the result right away, it's access. You know, what's asking for is access. Second thing he's asking is the transparency and care coordination as well as shared decision making. So in a way, the way I look at it is, you know, we are again trying to build up the fine-tune of better one by meeting each chord. So in my personal experience of going through this journey of patient-centered care, I think that they all align and they all kind of complement each other, some of them more than other, but I feel that, you know, and in what Bob said, the holistic care, I call holistic with an H and W both, because when you implement the holistic care with the holistic purpose, but also keep a person as a whole in mind, that you're treating Bob McCleave, who has expectations, who was a runner, so can I get him back to where he was running? But one piece that I feel has always been missing is what we don't count is if Bob had to spend 10 hours every other week waiting in a hospital ER, that would effectively take 10 hours out of his life. And he's lucky to be here with us, but I see many patients who may not make beyond 6 months. So if those patients are hospitalized and if they spend 30 days out of last 6 months in life in a hospital, or if they spend 10 hours each week in a hospital ER, we are effectively kind of nulling the effect of life extension, because we are adding 20 more days, but those 20 days are spent in the hospital.
Wow, thank you. I think you had the next question, correct?
You mentioned
Who are you? And
Oh, I'm sorry. I'm Lisa Aker from Health Partners in Minneapolis. We're
Thank you,
a
Lisa.
multi-specialty group of about 3,000 clinicians. You mentioned that you engage with your staff, you have retreats and one-to-one check-ins, and as you've gone through this journey, what has your retention been like with your employees? And then also, when you bring a new staff member on board, how do you get them up to speed? I mean, what's your intake process of getting them up to speed along with everyone else, or everyone is running along at the same rate?
so the question, great question, because I was thinking the same thing. So you have some very unique attributes of your practice in terms of engaging your staff, the retreats, and the question is, what's the retention? Are you able to retain people in probably a competitive environment? And the second part of the question was,
When you hire
would you hire somebody? How do you get them embedded in the culture? How do you bring them into what sounds like a great environment for taking care of people?
Well, great question, and I have a great answer as well. So first of all, retention-wise, most of our nurses retired from the practice. So there were 3 nurses who turned 65 and they retired. So almost 90% retention rate. And for the new hires, it's surprising. Our patients' family members who are working in the hospital, oh, doc, can she come and work for you? So we've never advertised in general for hiring employees. Someone will say, well, I want to come and work for you. They land in the practice. So they're already primed before they come that what kind of environment do we have. And I have to give disclaimer, I pay 40% less than the hospital pays and still employees don't leave us. So when we go for the retreat, there's no, I mean, in my practice, there's no hierarchy. It's a flat organization. The front desk receptionist can walk into my door without having to be worried that I disturbed him. So the other feature we have is we don't wear watches and there are no clocks in dark patients' offices. And we don't have computers in patients' room as well. Because we want to give them a complete attention. If I have a watch and if I look at my watch, patient will think that, oh, my time is up. So, these are some of the minuscule things, but they make a huge difference in how we are perceived with patient.
Thank you. I'm cognizant of the time. We're at 4:15. I think we ended 4:15.
Watch off.
Take the watch off.
Somebody told me in my ear. You're absolutely right. Talk about small innovations that make a huge difference. I think we just heard a fantastic one, like just eliminate clocks. And I think about just the opposite in a practice I used to have in a community health center. We had dots on the clock to make sure we kept on pace, right? 20 minutes, 20 minutes, 20 minutes. So anyway, I really appreciate the attention. You can tell this is a wonderful, thank you so much.
Thank you.
And
So I just want to add one last comment.
Please,
Sorry.
you have the prerogative. And I was
So-
just going to say that I think there'll be something out here, in here afterwards, but we're going to be outside, okay? Go ahead.
So, when we decided to go for PCSP accreditation, my office administrator, who I've known for almost 35 years, he came from India. I helped him a lot. Brilliant guy, but he said, I cannot do this. And I said, no, we got to do this. He refused. So I said, then you don't have a place in this corporation. And he thought childcare business was easier than going through this. Now, I took on the challenge myself. So I'm running the practice. I have one of the busiest practices. And one question I asked myself, I said, if I feel comfortable injecting poisonous chemicals into a patient's body, and if I am willing to take that risk, this is not a rocket science. And then I did it all myself. So we didn't hire a consultant. We did everything together. And I think it's easy and doable if we don't look into silos. If you look at the holistic purpose of this transition, it's doable.
Wow. Thank you very much, everybody. Enjoy the rest of the conference.